I'm Dr. Larry Santora.
I'm Heidi Cortese.
And welcome to Health Matters. Currently, 5.2 million Americans have Alzheimer's disease. On the show today, we're very fortunate to have one of the world's leading authorities on this disease. He's going to discuss all the latest treatments.
We'll also learn about recent improvements in detecting breast cancer. And this new technology is available right here in Orange County. And what's the difference between virgin and extra virgin? Now, I know what you might be thinking, but later on in the program, Larry will clarify and explain what's so great about olive oil.
Our first guest today is Dr. Earl Carlin. He's one of the leading authorities on Alzheimer's. He was recently awarded the Lifetime Achievement Award for Alzheimer's research. He's a professor of neurology at the University of California at Irvine. He's also the director of the Institute for Brain Aging and Dementia. It's a discipline he's been studying for almost 20 years. Thanks for coming, Carl.
You're welcome. Glad to be here.
You know, this is one of the scariest diseases. When patients in my office come to my office for other things and they think they're having memory problems or dementia or Alzheimer's, it frightens them more than heart disease or cancer. And I guess it's a sense of losing control, it's losing who you are. So what is dementia, what is Alzheimer's disease, and how do people distinguish the two if there's such a distinguishing characteristic?
Alzheimer's disease is really a loss of learning and memory, and eventually people lose what they call activities of daily living, which mean the ability to take care of themselves, to interact in normal social settings, etc. Alzheimer's, though, is a part of a broader classification called dementia. And dementia is the same features, but there's other types of dementia. Nonetheless, Alzheimer's is the major form of dementia and the most serious threat to the nation and the world.
So is it likely that the incidence is going to go up as the population ages? This quote is 5.3 million Americans now. What do you think is going to be?
It's actually projected to go up to 15 million, probably by 2050, because of the increased aging population. And also, there's big concern about the way people are taking care of their health today.
So it's not just because we have more people living till they're 85, and so, but say if everybody was still living until they're 70, is the 50 to 70 group, is there a higher incidence of Alzheimer's in that group also? Or is it just that we have a population that's living till 85 or 90?
It's mainly the increase in the age of our population, and not so much the fact that somebody at their 70s would be getting Alzheimer's disease. There's no evidence for that right now.
So, you know, all of us forget things. We forget our keys, we forget a word, we forget a line on a show. We want to forget our birthday as we get older. But when somebody starts doing that, how do they know it's just the benign type of thing that we all occur, or how do you know it's something to worry about?
People forget forget things right and left. I mean, it's part of normal life. And, you know, when you get older, you're more conscious of it, for one thing. So you lose your car in the parking lot, or you forget somebody's name after you've just been introduced. Some of that is normal. The problem that you can identify is if you've had some conversation with somebody or done something, you know, or had something to eat, and you just cannot remember it at all. You know, after several hours, it's just a big blank. That's a problem, because that indicates that you're not functioning in a normal fashion. Maybe once is passable, but if it happens repeatedly, then you have to start worrying about it.
We hear a lot about supplements like ginkgo biloba improving mental acuity. Is there any validity to that, or could it abate any onsets of Alzheimer's or dementia?
You know, currently there are a number of clinical trials that are going on because the ginkgo story was really very qualitative and didn't have really good clinical studies backing it up. That study is almost done now, so we'll get the answer on it. But the bottom line is there's no known supplements that just will erase the disease or even slow it down currently. There may be, but we don't know them yet. Now, in terms of lifestyle, you know, I think there's really increasing evidence that, you know, individuals can help, you know, offset the risk for decline with simple lifestyle changes, which is really a new form of medicine when you think about it, because things like exercise now are showing to be good for heart disease, good for risk of diabetes, and good for Alzheimer's disease. So that's very exciting, and good social enrichment. And then taking care of your diet.
Some of the studies with anti-inflammatory drugs, whether it's the anti-inflammatory properties of like a drug like Advil or aspirin, I mean, how much does inflammation of the brain or that type of issue, would those type of supplements or drugs be appropriate for somebody if they want to say, I know I don't have Alzheimer's now, but I want to do something simple in addition to diet and exercise? Would you ever recommend anything like that? Take an Advil a day or take an aspirin a day?
There is evidence that these types of anti-inflammatories will postpone the risk and push it out. The clinical trials have been less than decisive. Nonetheless, I personally believe that inflammation in the body is enough of a risk factor, so I will take Advil and Motrin myself, which I guess shows you where my conclusion is. If you don't react to it and you don't take it on an empty stomach, is it going to hurt you all that much? No, not really.
Are there distinguishing characteristics on the brain? You brought the brain model. If you did examine the brain in somebody with Alzheimer's, would you find any particular plaque or anything in the brain that would, can you show us where it might be?
Yeah. Well, what you'd actually find is in even a mild case of Alzheimer's disease, there's structures, sort of over here that would start to shrink. And then within this, there's a structure called the hippocampus, which is involved in learning and memory, that will actually be smaller. And then finally, the whole brain actually shrinks about 30%. I mean, it's pretty scary when, in a late-stage Alzheimer's patient. That you can see by imaging, and in fact, sometimes when people come into a doctor's office and they want to know, do I really have Alzheimer's disease? And you do a few things, rule out other causes, etc. They will take a brain scan and see if their brain is normal or not.
The size of the brain is one of the indicators then as to whether or not a person would have Alzheimer's?
Well, when the size starts shrinking, usually there's degeneration happening, and that's the signature of Alzheimer's disease. Correct.
So there's no particular plaque or scar tissue that can be identified that say this is characteristic of Alzheimer's. To make the diagnosis, if you examine the brain, you'd have to see this type of plaque, or it's just general shrinking of the atrophy of the brain tissue.
You really can't tell when a person's alive, what type of pathology and how far it's progressed.
Yeah.
There are new imaging methods that will allow you to look at what they call plaque, which is one of the signatures of the disease. But frankly, the latest findings are that some normal people have plaque buildup already, and they're fine. And that's one of the ironies, is that some people will absorb some changes in the brain and still be fine. And I think that they probably have built reserves up through education, through, the proper maintenance of their lifestyles and their diets and so on, and their medications, and they're taking care of other diseases so that it doesn't converge on their brain.
So they compensate whatever deficiency they may have in this piece of the brain, they may compensate.
Correct.
Over. Yeah.
Correct.
So is a personality change a big part of it? I mean, changes in hygiene or temperament or of Alzheimer's, is it?
Yeah, later in the disease, one of the real signatures is a personality change. And I mean, in our clinic, for example, we will see a range of behaviors. Some individuals will actually remain so nice and, really friendly, and they just want to reach out to people. Others get nasty, they get abusive, and they can become serious behavioral problems. But you can't predict at the onset how a person's behavior is going to and their personality is going to change. What
is the future in preventing this? Do you have is it a vaccine? Is it some type of genetic combined with genetic testing?
No, that's the great question. I think the first thing is that we've now got more ongoing clinical trials to test various therapeutics than we've ever had before. We've almost tripled the number of trials going on. One of the most promising ones is the vaccine, immunization. Now, we're sort of just at the early stages of getting that data in, so it's not all in, but within a couple of years or a year even, we'll find out whether immunization is going to work. Now, they're not trying people that don't have the disease yet. So we're going to get the answer on people that have the disease. Does it help them, get better? But the other promising things are there's a number of medications, including, a couple of Chinese herbals that are being tested now, which is pretty exciting. You've got centuries of qualitative data, and so now, Western medicine and the rigors of scientific clinical trials is coming in to test some of these. And, I'm pretty optimistic that there may be something really come out of that. And then the third revelation is really simple behavioral change can make a difference in terms of delaying the onset of disease and even have an impact on somebody that has Alzheimer's disease. I think the worst thing is just to put them in a corner, put them in a room, and forget them. The people that are in exercise programs, enrichment programs, are doing better.
And with other people, having
That's
some
correct.
sort of social interchange.
Correct.
Well, thanks. So this is very, very informative, because as scary as it is, at least there is some hope out there. There is some optimism that maybe we can intervene with this horrible disease. Thanks so much for coming today. It was a great discussion. We appreciate it very, very much.
You're welcome. Pleasure.
And congratulations on your
Thank you.
award.
Fact or fiction? Eating chocolate and fried foods will give you acne.
Fiction. Current medical knowledge gives no support for a relationship between food and acne. Therefore, it may be healthier to avoid sweets and fried foods, but it won't improve your skin.
Breast cancer is the second most common cancer among American women, and the chance of developing invasive breast cancer at some time in a woman's life is about 1 in 8. According to the American Cancer Society, there will be about 183,000 new cases alone this year.
Our guest today is Dr. John West. He's the co-founder of the Breast Care Center of Orange County. The center offers patients the latest technology in breast health, diagnosis, and treatment. Thanks for coming, John. We've known each other for 2.5 decades almost, and you've always been on the cutting edge of this. How did you get involved with the breast cancer specifically?
Well, I was always interested in the problem of breast cancer because it's such a devastating problem, and I had been taking care of women for years, and when the mammography came out, we saw the excitement of catching these cancers early. But what I found that there was a lot of delays and frustration, and the patient that really got me got me going on this was a patient who came to me in about February, and she had in December found a breast lump, and it took her weeks to get in to get a mammogram, and then weeks to get the additional views, and then her doctor took another week to see him, and then he finally sent her to a surgeon. The surgeon couldn't fit her in, and she finally called me and said, please, will you see me? Well, I saw her that day. We did a needle aspiration, made the diagnosis, gave her a plan of treatment, and she said, you've got to do this for other people. This is the way breast cancer should be cared for, and that was what motivated me to develop a comprehensive breast cancer program that includes imaging with mammography, ultrasound, MRI, the surgeons, the surgical care, the plastic surgeons, the oncologist, the radiation therapist, a totally integrated program where people talk to each other, can develop a plan for the patient and make sure that her needs are met, that her questions are answered, and she feels part of a team that really knows how to take care of her.
So I think that unknown, what is it, is just excruciating for most
the amount
people.
of suffering that these women go through when somebody calls them and said, that gets a letter in the paper, in the mail, and says, you have an abnormal mammogram. Well, her first thought is, I'm going to die. And so she has to call right away and get in, but they can't get her in for a few weeks. And then she's got to wait for that report. And it just isn't, our system now, the woman comes in to see us, they get the mammogram, the additional views, the ultrasound, the reading, see the surgeon that day, and everything's done within an hour visit where it's taken care of. And then they're either set up for additional biopsies if needed, or if everything's normal, they're told they're normal, do your breast self-exam once a month, and we'll see you in a year. And it works so well.
And you've been doing this for years like this. I mean, You've really been cutting edge. I'm impressed that in my practice, even though it's a cardiology practice, I see so many women with breast cancer, maybe 3 or 4 some days. And I get the sense that there's this epidemic out there.
There is an epidemic going on. I mean, I think everybody in this country has had a family member or a friend that's been somehow had an experience with breast cancer. And the good thing is these cancer patients now live so long that they have a lot of time to share their stories and kind of motivate us. One of the ironies of breast cancer is that it's a disease that's more common among wealthy people. So if you get nations where people work out in the farms, in the third world nations, that the ladies are very thin growing up. They start their period in 17, 18. They get pregnant early on and have a couple of kids and then go into menopause. That's a major protective factor against breast cancer. Whereas in our community, people are very well nourished. They tend to be a little heavier. They start their periods real early. Then they delay the onset of the first pregnancy, sometimes going to grad school or whatever. And all these expose the women to longer cycles of estrogen, which stimulate the breast and make the breast at more risk. So it's surprising when you look at the United States, the more affluent areas tend to have a higher risk of breast cancer.
So the sense is there are not hotbeds in the country where, like, maybe with other kinds of cancers that have more breast cancer for any other than the affluency.
I think the affluency is the only thing they've noted. There are some racial disparity. They've recognized that the uninsured, for instance, tend to get a later diagnosis, and so they have a poorer prognosis. And this is just one of those basic rules about breast cancer. If you follow all the rules right, if the woman starts getting her mammogram at age 40 or younger, if she has a family history, and she does it regularly, and she does the breast self-exam with confidence, which most women, of course, don't do. But when they're taught to do it, they can do it very well. That they have a doctor that they can go to who will evaluate any new symptoms and get the ultrasound or the MRI or the additional workup, whatever is necessary. If we put all these tools into action, we can diagnose breast cancer earlier and save lives. And I see that in my practice all the time. I see women who are doing regular breast self-exam find a little change, a little subtle change. They bring it to me. We examine them. Sometimes we can't even feel it. We put the ultrasound on it. There's a cancer the size of half the size of a pea. Well, with that woman, you just take it out. You do radiate. There's probably no chemotherapy. She's probably cured. If that same lady had waited, that could have grown and maybe be missed on the first mammogram and seen another year. And next thing you know, she's got a stage 2 or 3 breast cancer, chemo, mastectomy, radiation. So the real key, and I think for the public, is to understand the importance of not only knowing about breast cancer and being aware of it, but taking on a personal plan of action. So you know that when do you start your mammogram. If you're high risk, you've talked to a doctor. What does high risk mean? What kind of tests should I do? You do the self-exam. If something changes, you bring it to the doctor's attention. You make sure the doctor gives you a specific answer. And if tissue sampling is necessary, then you do it. But whatever it takes, you must catch it early, because that's how we really save the lives.
So it seems to me that, I mean, people shouldn't say we have all this high-tech stuff. We have mammograms, ultrasounds, MRI, but still, you're still advocating breast exam is really crucial for detecting
I think it's
early.
the entire package. And we see every patient I come in with a delayed diagnosis, I try to evaluate what could we have done better. Sometimes it's the woman doesn't come in for her mammogram, or she found a lump but she ignores it. Sometimes she finds a lump, goes to the doctor. He says it's nothing, or he gets a mammogram and it's negative. They don't get the ultrasound. There's so many pitfalls that can lead to delay that it takes, I think, the motivated and educated patient who's inspired to want to diagnose this early and wants to follow all the steps. It's kind of natural, I would think. Heidi, tell me, no woman wants to find a lump.
Absolutely not. And half the time when you're searching around, you think, is it one or isn't one?
Exactly.
And I can imagine if a woman does find a lump, it must be pretty difficult to own and say, gee, I need to go to the doctor and deal with this. It's very scary.
It's very scary. And you make a great point about the normal lumpy breast. First of all, we tell our women who are having periods, the best time to do it is a few days after you finish your period, when the estrogen levels are at their lowest. And the ideal time is then to go to a doctor and have the doctor do a complete exam, or examines the entire breast and said, okay, this is normal. Now, I then take my patient's hand and I take them through the exam and say, close your eyes, put enough pressure on so you feel the bumpiness, and try to visualize that pattern.
Right.
And once you do that, we tell them to go home that night and spend 20 or 30 minutes doing it that night and the next night and the next night and the next night. Over time, they get a clear mental image of the normal. Then they do it once a month at the same interval in their cycle. If something changes, they pick it up and they bring it to the doctor. But I've had women come to me with little bitty cancers that they're found they're so small I can't feel them myself. I see them on ultrasound.
So you've established a baseline with them on on their own procedure, and that enables them to detect something that's abnormal. Speaking of procedures, we were lucky enough to go to Dr. West's center and see this new technology and his 45-minute round-trip diagnosis in action. Let's take a look.
This is one of our new GE ultrasounds, very high quality and extraordinarily helpful for us in taking care of patients. Particularly good in the patient under 30 where we want to avoid any form of radiation exposure. This allows us to use sound waves to characterize changes in the breast, and it's extremely accurate, and certainly in most cases will differentiate with a high accuracy between benign and malignant. We use it in almost all age groups, though. We know, for example, that some cancers will be missed completely on the mammogram and show up like a light bulb on the ultrasound exam. Normally, if we have a lump or a spot on the mammogram, we can characterize it before taking them to the operating room, and if it's a cancer, then we can plan the appropriate operation. But the ultrasound works really easily. It's absolutely painless. I'll show it on my arm here and light up my radial artery, which will show up in red. The red is a pulsating blood vessel. On the breast, it's pretty much the same thing. It's a warm gel. The patients find it a very easy procedure, and it's very quick. So our patients come in, get the mammogram, the additional views, they get the ultrasound on the same visit. They see me that day. I can go over if it's normal, everything's fine. If there's a problem, then we can get the plan of action started that day, and within a few days get an absolute answer as to whether a spot happens to be benign or malignant. Well, this is the newest state-of-the-art digital mammogram. The digital is so much better than the older film screen, and that the film comes up just like a digital camera. You can see it immediately and come up with a reading. The woman doesn't have to wait so long in compression, but probably the greatest thing is that we have much better visualization, particularly in women, younger women with dense breasts. And this allows us to catch cancers earlier and save more lives. The breast goes into the plate. The woman stands here. It goes into compression. So the breast is across here, and the picture is taken from down below. But the women is made pretty comfortable. The breast has to be pulled out onto the plate to get as close to the chest wall as possible. The nice thing about the digital is it's so fast. So the woman comes in, she get a couple of pictures, and she's out of compression, rather than staying in compression and waiting for that image to develop while she's uncomfortable. So this is a much faster, much more well-tolerated procedure, and much more accurate. So we've got the 4 views. This is the lateral view, left and right, and this is what we call a CC, or the cranial caudal view, looking straight down on the breast. It allows the technician to tell immediately if they've had adequate compression and adequate positioning. If there's a need for a change, they can, within a few seconds, readjust the machine or the breast and get that quality image. These then go to the imager, who reads the films while the patient's still in the room. The tech looks at the images, analyzes the images, makes sure that they're okay, that they're the kind of quality that the radiologist will need. These images are then transmitted directly to the radiologist. From there, they can go out to see me in the next door in the surgery side, so that we then see the patient with a complete mammographic workup, the ultrasound workup, a specific reading, and then we can go from there for a plan of action.
John, that was very interesting, and you be congratulated on setting up such a fantastic center. But I have a couple of things I want to ask you. One is, you mentioned estrogen exposure. How are birth control pills a problem for, or are they a cause of breast cancer, do you think?
No, it turns out that the actual birth control pill lowers the estrogen in the system, and the women, the studies, by and large, totaling all the studies together, show no risk factor whatsoever. So actually, they're protective. The issue we really get into is the postmenopausal use of estrogen, and we know that a lot of women after menopause are going to have hot flashes and night sweats, and some of them could be absolutely miserable. We know that for a few years it's pretty safe. We try to use as low a dose as possible, and then we try to taper the woman off if at all possible. I find that 20 or 30% of the women, even in the 60s or 70s, still have such severe hot flashes or night sweats that it becomes a balance between quality of life and estrogen. If they're going to stay on the estrogen, then we just follow them a little bit more closely. Fortunately, now we have the digital mammography that allows us to see into the dense breast, even in the older women, much better than the old film screen technology. So now we're not having as much problems with the dense breast that we had before. So if we again, take each woman and individualize her issues, her risks, her needs. We can set up a plan of action that meets her needs, and we have to be reasonable about it. I mean, sometimes menopausal symptoms can be so bad we do have to use the estrogen. We live with that, but we follow them a little bit more closely.
Thanks so much for coming. It was great. I mean, you've done a great service to the community, and you've been cutting edge and a great friend. We appreciate you coming on. It's very interesting.
Thank you, Larry. Thank you, Heidi. Appreciate it.
Thank you very much. Fact or fiction? If you go outside in cold weather with wet hair, you will catch a cold.
Fiction. Exposure to cold weather does not cause colds. Colds are caused by viruses. They occur more in the winter because people tend to stay indoors. This creates an environment for germs to spread.
Recent studies suggest that olive oil may be the best oil for your heart. Once again, the doctor is in. Okay, Larry, tell us, are all virgins created equal?
They are not. As far as olive oil goes, it gets confusing, but there's extra virgin olive oil, and then there's virgin olive oil, and then there's pure olive oil. And extra virgin is the purest. It's the most healthy. It's the first press of the olives. They put them in a press, squeeze it, and the juice comes out. And the virgin olive oil has similar olives, but they're less of quality, but it's still the first press. But then you get into the lower quality, like pure olive oil, or light olive oils, and those have all the same calories. They have 120 calories per tablespoon, but this has very little nutrients. So you're getting all the fat, calories that you don't want, but you don't have all the nutrients. And what's so great about olive oil compared to other other types of oil is that it's a monosaturated fat, and it's been proven to raise your HDL, the good cholesterol, so protects your heart, reduces triglycerides, which you want to, that's another type of fat. It cuts down inflammation in your arteries. We think it may help and cut down some cancers and gallstones. So if you want to spend your money on olive oil, it's better to get extra virgin olive oil, which is more expensive, but it's much more healthful for you. And the other thing is, you see the different packaging here. The tin tends to preserve the olive oil better because light degrades it and heat degrades it. So if you have your druthers, you want to get it in a tin or a very dark container and store it in a cool spot.
Now, you mentioned that 120 calories is 1 tablespoonful. Right. And so how many tablespoons are we allowed per day?
We're allowed about 2. And that's 240 calories.
So it's safe to say we want to have 240 calories of the really good stuff, because it's the same amount of calories for the light stuff, but you don't get the bang for your buck.
Absolutely. And you don't want to take olive oil in addition to the regular fats that you're eating. You want to substitute it, right? So you have that instead of butter. Dip your bread in that instead of butter. Sprinkle that on salmon or whatever, and have that as your salad oil rather than some less healthy oils.
Well, that was really interesting.
Thank you so much for joining us. We look forward to seeing you the next time. I'm Dr. Larry Santora.
I'm Heidi Cortese.
And remember, your health matters.
Be well.
Well, this is the newest state-of-the-art digital mammogram. The digital is so much better than the older film screen, and that the film comes up just like a digital camera. You can see it immediately and come up with a reading. The woman doesn't have to wait so long in compression. But probably the greatest thing is that we have much better visualization, particularly in women, younger women with dense breasts.